You know what is a preload? You know what is an afterload? There are some maneuvers with which changes in murmurs occur. Which murmur has effect on which maneuver has which effect on which murmur is a favorite question of the examiner. So first you know which murmurs decrease the preload, which murmurs increase the preload, which maneuvers decrease the afterload, which maneuvers increase the afterload. Let us be sure first. Well, salvo maneuver, standing hypovolemia, or if you give a vasodilator, they all decrease the preload. You agree with me? Well, salvo is against a closed glottis, you are doing expiration, forced expiration creates a positive pressure which will prevent the venous return, and hence there is a decreased preload. Right, doctor? Then, what increases the preload? If you are squatting, it will increase the preload. If you give intravascular volume expansion, increases the preload. If there is a bradycardia, why? Because bradycardia may there is a increased diastolic filling time for the heart if the heart rate is slow. So that will increase preload. If you give beta blockers also, that will increase preload. Clear? What decreases the afterload? Afterload come on a peripheral vascular resistance. Nitrates, they have a peculiar effect. Nitrates not only decrease the preload, they are also known to decrease in afterload. Decrease in afterload is good or bad for HOCM? Bad. So nitrates are bad for HOCM. Nitrates decrease the preload. That is also bad for HOCM. Two ways HOCM के लिए nitrates are bad. Nitrates being the vasodilators, they typically will lead to decrease in afterload. Now what increases the afterload? If you are squatting, what happened to preload? Preload increased. Even afterload also will increase. If there is any alpha stimulation, you don't know, alpha 1, alpha 2 may, alpha 1 receptor stimulation will lead to vasoconstriction. Beta 1 lead to tachycardia. Beta 2 leads to bronchodilation. Alpha 2 stimulation lead to brain may. You are having alpha 2 as presynaptic receptor, right? So that will decrease the sympathetic outflow. Hence we use alpha 2 agonists as the centrally acting antihypertensives. Anyway, pharmacology we will have a complete, I will not leave you without reviewing pharmacology for you, whether you are in final year or whatever, I don't care. So, hand grip exercise is another important thing which will surge your catecholamines and lead to development of increased afterload. Hand grip exercise. Now let us talk about two very closely important differential diagnoses. MVP versus HOCM. They are the two important entities which you need to basically know the difference. In mitral valve collapse may, what's happening? The chordae tendineae are holding the mitral valves, right? Chordae tendineae, from where are they arising? Left ventricle, say. They are holding the mitral valve from prolapsing into atrium and prevents mitral regurgitation, right? Normally. So, if there is a prolapse, what lead to increased amount of prolapse? If the LV size is smaller or bigger? If the LV size is smaller, the chordae tendineae don't have that holding ability, and hence prolapse will be more. So HOCM also LV size small हुए तो HOCM worsens, LV size small हुए तो MVP also will worsen. दोनों, both of them will worsen. But what is the difference? If there is any increased total peripheral resistance, मतलब aortic root pressure is high, if it is, what happens? What is the effect of it on MVP? The left ventricle will try to use more pressure to push blood if the aortic root pressure is high. Such a high pressure in LV also will worsen the mitral valve prolapse. But in case of HOCM, a high aortic root pressure improved or worsened? Improved HOCM. You didn't understand? Were you there when we are talking about see, I think if high aortic root pressure is there, why MVP worsens, that you understood, but you didn't understand why HOCM improve, no? HOCM is a dynamic obstruction. That's the reason as a teacher I can come late to the class. As a student you don't have a chance to come late. So now doctor, dynamic obstruction में क्या हो रहे हैं? Let's go back to HOCM. No, even one student don't understand, I don't want to go forward. अरे HOCM यहाँ नहीं है क्या? हाँ है. हाँ, HOCM में hypertrophied interventricular septum is there, doctor. Anterior mitral leaflet is there. ये दोनों एक दूसरे की तरफ आके they are touching each other. That is causing the left ventricular outflow into the aorta become obstructed. Now, if there is a high aortic root pressure, what is the left ventricle's nature to push blood into aorta? It will use more pressure, high pressure it will use. When it uses such a high pressure, then this subvalvular obstruction is no more a matter. Right? You got it? So, this subvalvular obstruction is no more an obstruction. When left ventricle is forced to use lot of force to push blood into root of aorta. But why left ventricle will be stimulated to use high pressure to push blood into root of aorta? If the root of aortic pressure is high. So high afterload will relieve obstruction in HOCM. High afterload will worsen the MVP. So if you want to differentiate, now MVP causes which kind of murmur? Which kind of murmur? MVP में होता है MR. जो मर्मर MR के वजह से होता है वो MVP का मर्मर है. MR का मर्मर सिस्टोलिक मर्मर है या डायस्टोलिक? Systolic murmur. Yesterday we have pan-systolic murmur. In this case it is not pan-systolic because regurgitation is not throughout the systolic. Right? So, but you have a systolic murmur. Right? So you have a systolic murmur in MVP with MR. You have a systolic murmur even in HOCM also. But how do you differentiate these two systolic murmurs? Systolic murmur of the HOCM and also MVP, दोनों will worsen. Both of them will worsen if you increase preload. If you decrease preload, both these murmurs will worsen. Didn't get? If you decrease preload, left ventricle size small and HOCM and MVP both will worsen. No, that we are clear. No, what we learned, let us not lose it. Right? Decreased preload will worsen HOCM and also MVP murmur, doctor. Those who don't agree, raise the hand. Decrease the preload, decrease the size of the LV, and the MVP prolapse will increase. HOCM dynamic obstruction also will increase. You agree with me? But if you increase the preload, if you increase the afterload, what is the effect of increased afterload on the HOCM? It will decrease HOCM, but increased afterload will worsen the MVP. So if you want to know whether this is a systolic murmur due to MVP or due to HOCM, what you need to do, doctor? You increase the afterload of the patient and see. अगर MVP का है तो systolic murmur वो वर्सन हो जाएगा. अगर HOCM की वजह है तो improve हो जाएगा. So that is how you differentiate between, by increasing afterload you can differentiate. But if you happen to decrease preload, both HOCM and also MVP murmur दोनों will worsen, because decreasing preload will decrease the chamber size of the left ventricle and worsen MVP and also HOCM. Clear? Right. So what are the maneuvers that increase the afterload, doctor? Increase the afterload. Ask the patient to squat and then check the systolic murmur. Ask the patient to do a hand grip exercise. Give something to do exercise. Today only you go to hospital. You ask your cardiology resident, भैया एक MVP का केस दिखाओ, please, please. He'll say, bed number 4, Savita Devi, 23-year-old, sweet, young female. Go and auscultate her. You go and auscultate Savita Devi who is sitting in the bed. Will you listen anything? No. You ask Savita Devi to stand and auscultate. Then will you listen MVP? Why? If Savita Devi stands, there is a decreased venous return. Decreased venous return will decrease the size of LV, and decreased LV size will worsen MVP. Then the click, then the murmur, then they will be audible. Classical spotter given in the exams in cardiology. They will put a MVP patient nicely holding her feet and sitting on the chair. If you auscultate, nothing you will listen. You ask her to stand for about 3 to 5 minutes, and then you auscultate, then you start listening the systolic murmur and click. That is a typical case of MVP. Right? Then give a hand grip exercise to Savita Devi who is having MVP. Right? Then what will happen? Hand grip exercise will increase afterload. Even afterload also will worsen the MVP. You agree with that? That's how you have to basically differentiate. So, both MVP and also HOCM, they become accentuated with a decreased preload. Okay? Then you do the afterload, which will differentiate the two. If you increase the afterload, MVP will worsen, but HOCM will improve. That's how you fundamentally differentiate, doctor. Okay? So now let us talk about quick summary of MVP. Ideally, I should block these things and ask you. Decrease preload in MVP? Close the eyes and tell. What is the answer? Murmur will increase. Increase preload, murmur decreases. Decreased afterload, murmur decreases in MVP. Increased afterload, murmur increases in MVP. Then HOCM. Close the eyes and tell. If preload decreases, HOCM murmur increases. If preload is increased, it's a very dumb way of teaching. If preload decreases, murmur increases, preload increases, murmur decreases, वो कुछ बोलने का बात है क्या? I am also becoming a university professor. Not agreeable. You teach only 2 things to students, not 4 things to remember. Because if the first thing is true, second thing is true. If the preload increases, murmur decreases, means preload decreases, murmur increases. There is no big fishy about it. But afterload increases, HOCM murmur decreases. But today when you go to the hostel dining room, you play this game with your classmates. They will be, if they answered, they are good students. Now doctor, there are many other causes for the systolic murmur. MR is a pansystolic murmur. Aortic stenosis is a ejection systolic murmur. But what is the effect of it on all of them of the preload? Suppose if you decrease the preload, what happens for systolic murmur, ejection systolic murmur of aortic stenosis? If you decrease preload, there is a decreased flow across the stenotic valve. So, a systolic murmur of aortic stenosis will decrease if you decrease the preload. But a systolic murmur of HOCM will increase if you decrease the preload. MVP का systolic murmur will increase if you decrease the preload. MVP HOCM का systolic murmurs will increase if you decrease preload. But aortic stenosis का systolic murmur will decrease if you decrease the preload, because decreasing preload is decreasing the blood flow across the stenotic valve, is what you need to ultimately remember. So that's how you will carry on your differential diagnosis. Now comes a very important question. Cyanosis which is relieved with squatting. What are the 4 cyanotic heart diseases? I told you 4 T's. T for tetralogy of Fallot, truncus arteriosus, transposition of great vessels, tricuspid atresia. 4 T's. You need to, even total anomalous pulmonary venous circulation also will lead to cyanosis. Total anomalous pulmonary venous circulation. You still remember what logic I told? What the confusion that will be there? You go and ask your friends. Total pulmonary anomalous venous circulation cyanotic होना है ना, cyanotic कैसे हो गया? First of all, he don't know whether it is cyanotic or acyanotic. That's a different story. You will have your distinction classmates in the reading room, no? That guy को पकड़ के वो acyanotic क्यों होना पूछेगा वो. Then what will you tell? In anomalous pulmonary venous circulation, pulmonary vein, instead of draining into left atrium, bringing the oxygenated blood, it is draining into right atrium by forming a common pulmonary vein and draining. Yes, day before yesterday we discussed, you know. So here what is shunting? From left oxygenated blood is shunting into the right side. Any left to right shunt should be acyanotic. But why TAPVC is cyanotic? The baby will not survive unless there is an associated ASD which brings back the blood of the right atrium back into left atrium. So because of the ASD only they will survive. If the ASD is there, but this kind, what kind of ASD is this? It is carrying the right atrial blood into left atrium, not the left atrium से right atrium को ले जाने वाले ASD नहीं है वो. इसलिए TAPVC is a cyanotic heart disease, is what you need to basically remember, doctor. Now comes a question. Why squatting decreases the cyanosis of tetralogy of Fallot? Simple. First of all, why cyanosis is there in the tetralogy of Fallot? You have one right ventricle and it is supposed to drain into pulmonary artery, right? But pulmonary artery में drain होने के लिए क्या दिक्कत है? There is a pulmonic stenosis, so it can't drain. So what are the other 2 things that are there in the tetralogy of Fallot? Tetralogy of Fallot is a combination of 4 things. You have one VSD connecting the left and right ventricles. You have overriding aorta. उसका मतलब क्या होता? वो अपने मुंह खोल के दोनों से खून पीने के लिए तैयार है. बोथ राइट वेंट्रिकल और लेफ्ट वेंट्रिकल दोनों के ऊपर मुंह खोल के बैठे हैं. ओवरराइडिंग aorta is there, right, doctor? So now the right ventricle is that newly married princess. She understood that pulmonic valve is a atretic valve here. There is a moody prince who married her. Useless fellow. For everything he is angry and he is not even caring how beautiful she decorated that evening. Then suddenly she found that there is a overriding aorta. That is, Princess Commander is also a handsome guy who is opening the options for her to drain into the into the aorta. So if the princess right ventricle drains blood into aorta, which is overriding, what is the भ्रष्टाचार हो रहा है? The right side blood is mixing with side. So उसके वजह से साइनोसिस होता। तो अभी स्क्वाटिंग करने से क्या फायदा है? अगर स्क्वाटिंग करें तो व्हाट इज द इफेक्ट ऑफ इट ऑन आफ्टरलोड? इंक्रीजेस और डिक्रीजेस? Squatting increases afterload. So root of aorta also become a stupid, senseless fellow like pulmonary artery. Then the princess will think all men are useless like this. I thought this commander guy is little better. So better to live with prince only, and she will once more start draining into pulmonary artery. So then the right to left shunt will diminish. और वो सीधा चले जाएगा. Squatting relieves cyanosis by decreasing the right to left shunt from right ventricle into aorta and increases the right ventricle flow back into pulmonary artery by increasing the afterload is what need to be remembered. So what are the three things that you give to the patient, doctor, who is having cough with a cyanotic spell? You ask him to squat, you give him an oxygen. And what is the cost of that cyanotic spells in case of why is it suddenly going to cyanotic spells? The pulmonary artery root, it keeps going into spasm. Whenever spasm is there, there is more diversion of the right ventricular blood into overriding aorta instead of going into pulmonary artery. Giving oxygen relieves spasm, giving morphine relieves spasm. Squatting will increase the afterload in the root of aorta and discourage the right to left shunting is what you need to ultimately remember, doctor. So that is a very, very important story. But before we, anyway, in pediatrics, we are going to have excellent teacher from Kakinada. Madam will explain you all heart diseases very well. This session we have one of the excellent faculty from Kakinada in pediatrics. So that's the story, doctor. Then before we go away from cough, I want to ask you, you listen a systolic murmur in cough. Is that systolic murmur is because of the VSD or is it due to pulmonic stenosis? What is your answer? If you say VSD, examiner will fail you for next 6 months. The murmur, systolic murmur which you listen in cough is due to pulmonic stenosis, not because of VSD. VSD is a very silent VSD it is. It doesn't make much of noise and sound. Pulmonic stenosis in contrast is responsible. Ultimate prognosis of cough is dependent on VSD or on overriding aorta or on pulmonic stenosis. Pulmonic stenosis is a deciding factor of the ultimate prognosis is what you have to ultimately remember, doctor. So this is all the story called as dynamic auscultation.